for taking the time to be part of this session. And my name is Naeem Al Hassan, and today I will be presenting finding from our systematic review titled Smart Accessibility and Quality of Life in Education. Indeed, this presentation reflects a month of work analyzing how inclusive design and smart technology intersect, especially for students with disability, in shaping learning outcomes and overall well-being. I'm pleased to share insight that we hope will support more inclusive and impactful educational practice. We often celebrate the rapid digital transformation that occurred during the pandemic. Yes, it's brought innovation, flexibility, and access, but it also brought something less visible, exclusion. What we found is that smart technology, despite its potential, can widen gap when not designed inclusively. Students with disability, for example, were often left out of planning, design, and decision making. This research is not a celebration of digital innovation, it's an examination of its consequences. It also asks, are we truly including all learners, or are we simply assuming inclusion because tools are available? Inclusion is not about availability, it's about impact, and that is exactly what this study aims to uncover. To answer this question, we needed a method that goes beyond opinion or isolated cases. So we conducted a systematic literature review, a method that synthesized evidence across multiple studies. We indeed analyzed 9 empirical studies published between 2015 and 2023, all focused on secondary education, students with special needs, and the impact of smart technology on inclusion and quality of life, not just academic performance. We applied the PICO framework, structure method used in evidence-based research to evaluate the target population, students with special needs, the intervention, smart technology, any comparison, and the intended outcome, specifically learning well-being, autonomy, and engagement. This study just explore what smart tools can do. It's explore what they actually mean for students to live. When we say that education enhances quality of life, what exactly do we mean for students, especially those with disability? According to Robert Shaluk framework, quality of life is not one thing. It's made up of 8 distinct domains. Each domain reflects a critical dimension of students' well-being, growth, and participation in life. Let me briefly highlight some of these domains. First, emotional well-being. This is about how safe, respected, and emotionally supported a student feels in their learning environment. Closely tied to this is autonomy and self-determination. It asks, can students make choices? Can they set their own goals and feel in control of their learning experience? Let's turn to inclusion, not just being physically present in the classroom, but being actively involved and meaningful, included learning and peer interaction. Social relationships are equally vital, especially for belonging and collaboration, having friends, being able to collaborate, and experiencing a sense of connection with others. Finally, we cannot overlook right and development, because access is not just about entry, but growth expressed opinion, and pursue fulfillment. Now, here is the challenge. In most educational technology implementation, these deeper dimensions are overlooked. We focus on devices and apps and platform, but we rarely ask, does this technology support emotional well-being? Does it foster autonomy and real inclusion? For students with disability, success is not just measured by test score or content mastery, it's measured by confidence and choices. In reviewing the literature review, we began to see three recurring threads, three lenses through which we can understand and real impact of smart accessibility: pattern, pitfalls, and possibility. First, the pattern. There is a growing evidence that smart technology can work when they are purposefully designed and thoughtfully implemented. Several tools have shown the ability to increase student motivation, independence, and engagement, especially when they incorporate assistive features like text-to-speech, customizable interfaces, or self-monitoring function for students with executive functioning challenge. But unfortunately, these successes are not the norm. Most technology were not designed with were not co-designed with learner, especially learner with disability in mind. There is a common mismatch between what developer build and what students actually need. Indeed, we also found a significant lack of teacher training, which make even the most innovative tools ineffective in real classroom. And perhaps most critically, institutions often adopt technology without ever evaluating their impact on inclusion or equality or quality of life. The result, tools that are available but not accessible in meaningful way. And this brings us to the most important part, possibility. When students are involved in creating these technologies, when their lived experiences shape the design, we began to see real, measurable improvement in quality of life outcome, from emotional well-being to autonomy. Inclusive design is not just about feature, it's about shifting who sits at the table when the decisions are made. Inclusion must be intentional, not assumed. Just because a tool exists doesn't mean it's included. Inclusion needs to be designed, implemented, and evaluated with purpose. Or we risk reinforcing the very barrier we claim to dismantle. Okay. Uh, After reviewing the studies, we needed a way to synthesize the best practice, something that could guide both policy and practice. That's where the diamond model comes in and a blueprint for building smart accessibility that is not only inclusive but sustainable and learner-centered. We start with functional value. Does the technology actually support learning? For example, a reading tool that converts text to audio can make abstract content accessible to a student with dyslexia, not just faster, but with more comprehension. Next is utility. Can the technology be used across different learning contexts? A tablet app that works both in class and during home-based learning or that support multiple subjects reflect high utility. Then we look at accessibility. Is the tool usable by students with diverse needs? This goes beyond just adding subtitle or screen reader. It means inclusive interface design, alternative input, and sensorily friendly option. Finally, adaptability. Can the tool evolve as student need change? Think of a self-monitoring app that adjusts prompt as the student gain more independence. It grows with the learner. What makes this model different? At the heart of this model is a student co-design, including the learner in shaping the tool, not just consuming it. And the role of institution to audit, adapt, and refine. This is not a set and forget model, it is a living process. Each of these pillars strengthen the other. Real inclusion is not just about presence of technology, its relevance and responsiveness. Beyond access, real inclusion is not about access, it's about agency. It's not just about giving student tools, it's about giving them control. Agency means students are not just passive recipient of content, they are active decision maker in their own learning journey. What should smart tech really do? Enable decision making, a platform that lets students choose how to engage with content, whether by reading, listening, or watching, immediately respect their preference. Also support autonomy, assistive app that allow learners to work at their own pace, help them build ownership over their progress. Also, encourage self-regulated learning, tools that track personal goals or give student feedback they can act on, promote lifelong learning habits. Actually, inclusion is not a feature, it's a philosophy. It's not something we add on. It's something we design from the start. Let's be honest, equity cannot be aspirational, it must be operational. It's not enough to say we care about equity in education. We have to act on it, embed it, and measure it. The gap between intention and impact is where many well-meaning initiatives fall apart, especially when it comes to students with disability or diverse learning needs. To move from intention to action, actually we need to rethink where we invest our time, energy, and resources. And here, three strategic shifts I believe we must take seriously if we want to translate equity into practice. First, invest in educator training, not just hardware. Too often we focus on devices, platform, and access points, but if educators aren't confident in how to adopt and personalize these tools, they won't work. We need to train teachers not just in what the tool do, but how to use them for inclusion and autonomy. Second, let the student shape the tech they will use. We need to listen to students, especially those with the disability. Their feedback should inform what gets built, how it gets used, and how it evolves. Co-creation is not a luxury, it's a requirement for meaningful relevance. Third, evaluate impact based on quality of life, not just access. So it's time to go beyond usage statistics. We need to ask, is this technology really improving the student confidence, their independence, their sense of belonging? Because that's what equity actually look like in practice. If we are serious about equity, then we must measure not just what we give, but what our students gain. What kind of future are we building? Um, Actually, we have seen what possible. We have seen what happens when inclusion is intentional and what happens when it's not. So the real question is not about technology anymore. Uh, it's about values. It's about designing system, not just tools. System that makes students feel seen, heard, and respected. Because in the end, we are not just distributing devices, we are shaping experiences, we are building futures. At this point, I'd like to offer a shift in perspective, one that challenges us to move beyond service level metrics. So, how should we reframe our approach to inclusion? Let's shift our thinking from innovation for all to inclusion for each. Let's shift from access as a number to equity as lived experience. Uh, and Before I close, I want to sincerely thank you for your presence and your attention. Thank you again.
Thank you, Doctor, for your excellent presentation.
An overview of why the study was done, and specifically the time period at which it was done in India. So to begin with, the series of events that happened. So as we know, in December, late December 2019 is when China declared the first COVID-19 cases. Later in Jan 30, where WHO actually declared it as a public health emergency of international response. And just about the same time, India detected its first case in Kerala, which is down south of Mumbai. So, soon after that, the pandemic was declared by the World Health Organization just about in March, around March 15th. And in India, the country had had a nationwide lockdown just about the 24th. So in addition, we saw a high number of cases. We saw that the cases were rising high despite the lockdown, despite the international restrictions, travel restrictions, and so on. So some initial measures that were taken, we had implemented the international flights were suspended from March 22nd, 2020, as a part of measures to control the incoming cases and limit transmission. And nationwide lockdown implementation was done on March 24th. That's literally about 12 to 15 days after the declaration of a pandemic by the World Health Organization. Then simultaneously, I think there were some measures taken by the government, maybe not up to the mark, but yes, there were some measures taken up to address the, the knowledge gap related to COVID-19. So coming to Mumbai, so the city is actually a major metropolitan city in India, and it's actually a business hub, and there's a large number of working class community, and there's a lot of international travel, and also the public in the city. There's a it's a very densely populated city, so there's well connectivity also within the city. So we had faced some challenges in terms of implementing these measures in terms of lockdown and also addressing people's concerns. So one other important thing is, like when this COVID-19 had come out, we were short, there was some shortage of kits, we were just, there were some supplies, but not how many were needed. And obviously there were some gaps in public awareness. So the reason I'm taking you through is just so that you understand. So through, the events which made us think about this study. So to begin with, the objective of this study was to evaluate the hygiene practices among international travelers and predictors of COVID-19 positivity, which was the first wave of the pandemic in Mumbai. It was also to assess the utilization of services provided by the government for COVID-19. So you can see this was actually a news article that was released just about then. So it was, and actually that's a small picture of me there. They just happened to take a photo and we were not aware. And it was just the first set of people who had come down for screening. And the center was the first center in Mumbai that was selected to screen international travelers who were suspected of COVID. So the study setting, like I said, it was the first center authorized to screen. The study population were travelers from countries that had known to have positive cases of COVID-19 or anyone who has come in contact, because by that time we had a few reported cases down south of COVID-19 positive persons. The study design was a cross-sectional study, and we actually conducted the data collection telephonically. The reason is because, just being in that OPD, we knew that the mode of transmission was fomites, and patients were really reluctant to touch anything. So, making things worse, we didn't want to make things worse. And also considering this is a pandemic, we decided that the telephonic route would be the best way to interact with patients and get their data. So we developed a structured questionnaire. It was an interview method that was conducted over the telephone. We used a diverse linguistic approach because of all majority languages, to interview participants as per their preference to enhance response accuracy. So for the data analysis, we first tested the association of COVID-19 positivity with socio-demographic profile and independent variables of knowledge and hygiene practices. Variables that were significantly associated were further underwent regression analysis. So the independent variables are such as education, status of the participants, the occupation, what they do, working for essential services, awareness of the spread of the infection, read or seen any document related to, the guidelines of COVID-19, hand hygiene, frequency of washing hands, increased frequency of washing face, cough etiquettes, social distancing, and strictly following lockdown measures. So this was just to show you some of the measures we all know about them, released by the government and yeah. So results. So what we found is that a large number, about 79% of the participants were male. So there was a significant gender, we saw a imbalance in the study. So that probably could be because, most of the most of the travels were related to work, and also people who came in were also the ones who came in were working outdoors, so they were mostly the males. So that's why. In the age group, we had majority of them were between 18 to 40 years of age, with a mean age of about 24 years. So there were younger individuals represented in our study, and the higher positivity rate, we noticed that were among the lower education. So we had a diverse population. Among the 1,000 participants that we contacted telephonically, we got consent from about 950 participants who gave us a complete response to the complete questionnaire. So in that, we noticed there were people from diverse backgrounds, and also, laborers and the people who were working nearby who were really anxious and wanted to know more, who came into the OPD for screening. So in that particular population, we found that we've tested, there were about 22% who were positive. There were about 13 or 14% who were positive, which also had a positive relative. And then there were about 4% who were negative, but who had a positive relative, and about 60% who were negative. So another important thing at that point in time was to know, even though these services were released late by the government, we were curious to understand how were the people gaining their information about COVID-19, because there was a lot of misinformation and miscommunication. And, I guess, so the government had released a helpline, which is 1916, and they developed an app so that people could be more aware. Surprisingly, the app was only downloaded by 37.6% of the people. So when we inquired why, they were like, they didn't have enough space in their phones. They felt they didn't know how to use it and how helpful it was, in what ways. So that was the other thing. And another interesting thing is we got majority of the information that common man was getting in our cohort was through news channels, and of about 43%, which is pretty big, because we also realized that maybe government authorized guidelines should be published without really editing them, because we realized that these news channels or radios were just taking pieces of information. Maybe they were kind of making it a hype, and that created a lot of panic in the people. So finally, then, to understand the predictors of COVID-19 infection, in the first wave, on the first people who entered Mumbai city, who was suspected of COVID. So we found that having knowledge of the spread of COVID-19, having read or seen an official document on hand hygiene, like what are the different steps of hand hygiene, face hygiene is also important, and covering mouth while sneezing or coughing, maintaining 1 meter social distance most of the time, cleaning with specific disinfectants. For example, it's your phone, or it's something, a pen, or something that another person might hold. So using appropriate disinfectants to clean them, and strict lockdown compliance. So these were found in our initial association. Then we further went on to those and did a regression analysis to see exactly and to get an odds ratio. So we found that reading an official hand hygiene document or information could reduce the risk of COVID-19. Reduced face hygiene, less frequent face washing also increase the risk of COVID-19. Following cough etiquettes also reduce the risk of COVID-19. Not maintaining social distancing also increase the risk of COVID-19, and not strictly following lockdown. So in summary, there were demographic insights, knowledge disparities, and practice correlations that were associated with the risk of COVID-19 in our cohort. So insights that we gained, because when we were telephonically interacting with people, they had enough time and they were just trying to vent out and express their experiences and express what was going through their mind. So we kind of got a much deeper insight into what was going through and why. I think that kind of gave us upper hand, because just filling out a questionnaire would have restricted the information in so many ways. So yeah. And the other thing was, so another important highlight is emphasis on health education, utilization of trusted media, and addressing socioeconomic barriers. So the reason why we're seeing socioeconomic barriers is because many of the participants were from the labor class, like they were construction workers, they were people who were, working, in various sectors, but who came in, they were anxious and to know if, they're just having a runny nose, could they be positive? So when we were interacting with them and trying to know their knowledge and practices, they were like, we know that we have to do our hand wash, but we don't have the soap. The shops, because of the lockdown, most of the important places were closed nearby, and because they were not having an earning at that point of time, they didn't have any income, they felt like they didn't want to invest in a sanitizer, so which was little expensive. So definitely some small things, but definitely important at that point in time. So addressing miscommunications and information gap, understanding, much later down the line, I think this, apart from the fomites and this, there was a press release about the airborne, and, there was a lot of debate about it, and was it not? So I guess that conveying it to the common man and making them understand that what what is the transmission mode and why, and how you can protect yourself is important. Hygiene practice discrepancies, we found that many people, especially when, disposing the mask, I think a lot of people did not really know where to throw it, how to throw it, should they just, yeah, so that kind of is also not a good idea, because then people who are collecting them or in that could also spread the infection further. And effective communication strategies are extremely important. So in conclusion, we did in our study, we understood that there was significant knowledge gaps. We need targeted education and through health campaigns. So we kind of since the study went a little bit in depth, so we were able to suggest a little bit of the outreach activities to address the knowledge gap, behavioral change communication to help people to address, and especially wearing a mask was really a difficult task, and people were just refusing, in the third wave, the second wave, they were just so tired. So I guess just to see how the government, or how as as healthcare workers, how we can put across and how we can convince them to carry out this particular practice, and by addressing their concern, and resource distribution initiatives. So ensuring there are enough supplies for like sanitizers and masks, and even for the common people. So thank you. That's my presentation. I'd like to acknowledge my Dr. Ruchita Hadie and Dr. Chandrakant Pawar, who had helped us through the study, and recognize and all the interviewers and participants of the study. Thank you.
Thank you very much, Doctor, for your presentation. And now we are welcome to any.
Good morning, respected committee members and all participants. Thank you for taking the time to be here today. My name is Irawati Hawari. At this time, I will focus on one of the long-standing yet overlooked disease, leprosy. Please allow me to share my presentation. Clinical profile, transmission factors, and early disability, prevalence of leprosy, a single-center observational study at Bunda Pembantu Abadi General Hospital Naob, East Nusa Tenggara, Indonesia. For introduction, as we know that leprosy is chronic granulomatous infectious disease that causes peripheral neuropathy with disabling manifestation. This disease is caused by Mycobacterium leprae, which lives in cool body surface temperatures and enters the body through the nose and skin. This disease primarily targets Schwann cells in the peripheral nervous system and skin macrophages. If left untreated, it can lead to irreversible damage such as nerve deterioration, loss of sensation, and disfigurement. Clinically, leprosy presents with a wide spectrum of manifestation. These range from hyperpigmented or reddish skin lesions with sensory loss to more severe deformities and disabilities, especially in advanced stage. Despite an introduction of multi-drug therapy in the 1980s, leprosy still persists as a global public health issue. Many cases continue to go undetected, leading to ongoing transmission and disability. In 2022 alone, over 140,000 new cases were reported worldwide. The country contributing the highest number of cases include India, Brazil, and Indonesia, highlighting the continuing burden of the disease in certain endemic regions. According to the World Health Organization, the target for leprosy elimination is less than 1 case per 10,000 population. However, in 2022, Indonesia reported 1.17 cases per 10,000, still above the elimination threshold. In 2023, a total of 14,376 new cases were reported across 38 provinces in Indonesia. indicating that the disease remains widespread and uncontrolled in many regions. The persistence of leprosy is influenced by multiple factors. Biologically, the disease has a long incubation period ranging from 5 to 20 years, and drug resistance is an emerging concern. Socially, stigma around the disease leads to delayed treatment, seeking behavior, and low public awareness. People often hesitate to get checked or treated because of fear of discrimination. Problematically, challenges include limited healthcare resources, poor accessibility to treatment in remote areas, and weak monitoring systems. These factors hinder early detection and effective management of the disease. This study employed a cross-sectional observational design, aiming to assess the clinical profile of leprosy patients, identify risk factors related to transmissions, and determine the prevalence of early disability. The research was conducted at Bunda Pembantu Abadi General Hospital, located in Naob, East Nusa Tenggara. The study period focused on December 2023. The population included all leprosy patients recorded in December 2023 based on hospital medical records. A total of 130 patients were included as the sample size. For the inclusion criteria in this study, patients had to meet several criteria. First, they must have a confirmed diagnosis of leprosy based on clinical, bacteriological, and histopathological evidence following WHO standards. Second, they need to have complete medical records, and third, informed consent had to be provided. The data used in this study were retrospective, collected from existing medical records. The variables collected were divided into two categories. Demographic data include age, gender, occupation, marital status, and family history. And clinical data include vital signs, duration of illness, WHO disability grade, bacteriological index, and morphological index. As we know that leprosy is a chronic infection caused by Mycobacterium leprae, primarily affecting the skin and peripheral nerves, to evaluate the degrees of disability, we use the WHO disability grading system, where grade 0 indicates no disability, grade 1 indicates loss of sensation, and grade 2 refers to visible deformities. For bacteriological assessment, we use two indices: bacterial index, which is based on a logarithmic scale range from 0 to 6+, to estimate the bacterial load. Morphological index, which reflects the percentage of viable or solid sustained bacilli. Data analysis was performed using descriptive statistics processed with SPSS version 25. This study received ethical approval from the Faculty of Medicine, Tarumanagara University, and patient confidentiality was strictly maintained by coding all personal data. Participation was fully voluntary, and participants retained the right to withdraw from the study at any time. In terms of gender, 79.2% of the patients were male, and only 20.8% were female. This higher prevalence in males may be associated with occupational exposure and biological susceptibility. The patients aged from 7 years to 87 years, with a mean age of 37.6 years. The most affected age group was 31 to 40 years. accounting for 32.3% of all cases. Regarding occupation, farmers made up the largest proportion at 56.9%, followed by housewives at 16.2% and private employees at 15.4%. This indicates that individuals with outdoor or manual labor jobs may face greater exposure risk. From a marital and family perspective, 60.8% of patients were married, while 42.3% had no children, which may relate to age distribution or delayed family formation due to illness. Finally, when looking at the type of leprosy, the vast majority, 97.7%, had multibacillary leprosy, while only 2.3% had paucibacillary. And this suggests that most patients presented with a more advanced form of the disease, which may also relate to late diagnosis. And this slide highlights the risk factors and occupational insight observed in our study. High-risk groups include farmers who are exposed to contaminated soil and often have limited access to healthcare services. Housewives also face risk mainly through close and prolonged contact with infected family members, which increase the chance of household transmission. From a socioeconomic perspective, barriers such as poor hygiene, limited education, and delayed access to medical contribute significantly to disease persistence and progression. Gender-specific sustainability is another important consideration. Biologically, testosterone may influence immune response, possibly increasing male vulnerability. Additionally, from a sociocultural standpoint, men tend to delay seeking early medical care, which may lead to more advanced disease at the time of diagnosis. Now let's look into the clinical characteristic and nerve involvement in our patient population. The average durations before diagnosis was 2 years, with a wide range from 0.6 to 20 years. It's indicating considerable diagnostic delays in some cases. Based on WHO disability grading, 43.1% of patients were in grade 0, showing no visible disability. However, 17.7% were at grade 1 and 38.5% at grade 2, which indicates visible deformities. Only 0.8% were at grade 4, a very rare severe condition. Nerve damage is a key complication in leprosy. It's caused by immune-mediated attacks on Schwann cells, which results in demyelinization. Over time, this leads to ulcers, deformities, and even blindness in advanced cases. Importantly, longer disease duration before treatment correlates with high risk of disability. A meta-analysis suggests that for every year of untreated leprosy, the risk of disability increased by approximately 12%. To reduce the burden of leprosy, we propose 3 case area of recommendation. First, awareness of education. Targeted health education programs should focus on farmers and housewives, as they represent high-risk groups. In addition, campaigns for early symptoms recognition can promote timely diagnosis and reduce long-term complications. Second, strengthening the healthcare system. This includes training healthcare workers, to recognize and manage leprosy early. We also recommend expanding diagnostic and treatment access, especially in rural and undeserved areas, through initiatives like mobile clinics and telemedicine. Finally, we emphasize policy and collaboration. Effective leprosy control requires multi-sector partnership between government bodies, non-governments, and local communities. We must also focus on sustain and scaling up the existing control strategies to reach elimination targets. And for the conclusion, this study provides valuable insight into the clinical profile, transmission risk factors, and early disability prevalence of leprosy at Bunda Pembantu Abadi Hospital in Naob. We found that the majority of patients were male within the productive age group and mostly working as farmers. Interestingly, the lack of family history in most cases suggests that environmental exposure plays a more significant role in transmission. The mean disease duration was 2 years, indicating a delay in diagnosis and treatment. This correlates with the high prevalence of nerve damage, is 56.9%, which highlights the urgent need to early detection and timely intervention. Most patients were diagnosed with multibacillary leprosy, it's almost 100%, underlining the importance of active case detection, contact tracing, and public education to control transmission and reduce social stigma. That's all. Thank you for your attention.
And I also want to express my gratitude towards organizers and the conveners of this conference for providing me the opportunity to present my research work. So, my topic is the public healthcare evolution of city regimen adjustment amidst growing antimicrobial resistance. So, before we delve into the detail of our session, I would like to outline the key points of my presentation. First of all, I would like to discuss the overview of the gastric infection and then the introduction, then the pathogenesis, treatment, and after that, I will discuss the research objective, methodology, and future recommendations, and finally the conclusion. Right. So today I will begin by providing an overview of the gastric infections, focusing on their definition and the significance. So what are gastric infections? Basically, they refer to a range of the conditions caused by the microbial pathogens that specifically affect the stomach lining and the upper gastrointestinal tract. These infections can manifest as either acute or the chronic conditions, leading to symptoms like the abdominal pain, nausea, vomiting, and the indigestion. And such symptoms can significantly impact the patient's quality of life and place a substantial burden on the healthcare system. Now, let's consider their significance. Basically, the gastric infections are a widespread issue worldwide, and they are particularly prevalent in the developing countries where the poor sanitation and limited access to the healthcare facilities makes these infections harder to diagnose and treat. So, unfortunately, this has led to a substantial burden of the morbidity and the mortality in these regions. So now let's take a look on the common causes of the gastric infection. The first of all, the main causes include the poor sanitation, which often results in the contamination of the water and the food supplies. And this is a major problem in areas with inadequate waste management systems. Another significant factor is close contact with infected individuals, and this could happen in densely populated areas or the households where the hygienic practice might be compromised. Next, let's discuss the pathogens involved. So the most notable one is the Helicobacter pylori, right, which is a leading cause of the gastric ulcer and the chronic gastritis. And the other common pathogens include the Salmonella species, which are often linked to the foodborne illnesses, and E. coli, which is responsible for a variety of the gastrointestinal issues, and the rotavirus, which is the leading cause of the severe diarrhea. So these factors and the pathogens underline the complexity of the gastric infections, which make them a significant global health concern. Next, turn our attention to the Helicobacter pylori, which is a significant contributor to the gastric infection. Basically, it is a major cause of the two key conditions, which is the gastritis and the peptic ulcer, right? And gastritis refers to the inflammation of the stomach lining, while the peptic ulcers are the sores that develop on the lining of the stomach or the upper part of the small intestine. And both of these conditions are linked to the persistent or the chronic abdominal pain, and which can severely impact a patient's quality of life. So this is the background of the study that World Health Organization classified the Helicobacter pylori as a class 1 carcinogen and underscored its severe impact on the global health. And this bacteria associated with a risk range from 0.1% to 3% for the development of the gastric carcinoma, and the risk of less than 0.01% for acquiring the mucosa-associated lymphoid tissue lymphoma. So consequently, the H. pylori emerged as a significant infectious carcinogen on a global scale, which accounts approximately 780,000 cases of the H. pylori-related cancers annually. And it represents 6.2% of all diagnosed cancers cases worldwide. As we talk about the Asia, so it also contributes 75% of the global burden of the stomach cancer cases. And in the Pakistan, particularly in the Pakistan, it is a very alarming situation, and the prevalence rate is very, very high, which is almost 85 to 95%. Right. So if we talk about the pathogenesis, so basically, H. pylori infection triggered the chronic inflammation in the stomach, and this inflammation led to the breakdown of the stomach's protective lining and leaves the tissue vulnerable to the stomach acid, which results in that characteristic burning and the gnawing pain, which is so common in the peptic ulcers. And for many patients, the kind of the pain can persist for long periods, often leads to the chronic abdominal discomfort. And the pain may range from the mild to severe, or if left untreated, it can progressively worsen. So more serious complications such as the bleeding ulcers or even stomach perforation can follow. So this case highlights the critical importance of the early diagnosis and the effective treatment. So without proper intervention, the patient's condition could have escalated to life-threatening complications. And it also emphasizes the key role of the pharmacists, which play in the managing such conditions and ensuring the safe and appropriate antibiotic use to eradicate the infections and to prevent the further harm. So now, if we look into the global prevalence of the Helicobacter pylori, so we can see that in the developing countries, the prevalence rate is very high, which is almost 85 to 95%. While in the developed countries, the prevalence rate is comparatively low, it is 30 to 50%. As we talk about the region-wise prevalence, so highest prevalence rate in the South America, which is 69.4%, and the lowest prevalence rate is in the Oceania, which is 24.4%. And if we talk about the country-specific prevalence of the Helicobacter pylori infection, so the highest prevalence rate is in the Nigeria, which is 87.7%, and the lowest prevalence rate is in the Switzerland, which is 18.9%. Right. So if we talk about the Helicobacter pylori, so basically it is a gram-negative bacteria, which has the flagella, which has some motility in moving around, and some important virulent factors that Helicobacter pylori possesses, including the lipopolysaccharide, which help in adhering to cell. And another important virulent factor of the H. pylori is an enzyme on the surface, which is known as the urease. Basically, urease is very important for the H. pylori survival because it provides the basic environment. Right. And H. pylori also secretes some exotoxins such as the VAC-A and the GAG-A. So VAC-A essentially causes apoptosis of the cells, and GAG-A is responsible for disrupting cellular integrity and structure and also promotes the inflammation. So in the next slide, there are some challenges in the hospital management. So now let's discuss the challenges hospital faces in managing the H. pylori infection. The first major challenge is increasing the antibiotic resistance. And Helicobacter pylori has developed a significant resistance to commonly used antibiotics, including the clarithromycin, metronidazole, levofloxacin, and this resistance complicates the treatment outcome and reduces the effectiveness of the standard therapies. Another key challenge is limited diagnostic resources, particularly in the low-resource settings. So many healthcare facilities lack access to advanced diagnostic tools like the urea breath test or the molecular resistance testing. So without these tools, diagnosing H. pylori infection can be delayed or the inaccurate, which leads to the inappropriate treatment and an increased risk of the complications. Next, the third challenge is the need for the personalized treatment plan. So standardized treatment regimens may not work for all the patients due to the variations in the antibiotic resistance, patient comorbidities, and the adherence level. While the personalized therapies show promise, they require advanced diagnostic and the trained personnel, which are not always available in all the hospital settings. Lastly, we face the issue of the high reinfection rates. The reinfection often occur due to the poor sanitation, incomplete treatment, or the failure to completely eliminate the bacteria. So addressing reinfection requires robust preventive measures such as improving the sanitation and educating patients on adherence to the treatment protocol. So these challenges underscore the complexity of managing Helicobacter pylori infection in the hospital settings. So these are the current treatment options, which based on the regional resistance preference, patient allergies, and prior exposure to the antibiotics. Let's begin with the standard therapy in areas where the clarithromycin resistance is low, less than 15%. We recommend the standard triple therapy, and it consists of the PPI, clarithromycin, amoxicillin, or the metronidazole. However, in region where resistance to the clarithromycin exceeds 15%, so standard triple therapy loses its effectiveness and alternative regimens are needed. So in these high resistance areas, we recommend a bismuth-based cortical therapy or the concomitant therapy. Concomitant therapy uses a combination of the clarithromycin, amoxicillin, and metronidazole alongside a PPI. It is also a viable option in certain high resistance regions. So in this slide, we can see that resistance with the antibiotics has been developed in the various regions, especially in the Pakistan, right? And we can see that these regimens have been effective for the many years, particularly in the region with a low antibiotic resistance. However, the landscape is changing. Unfortunately, resistance has now developed to many of the commonly used antibiotics, including the clarithromycin, metronidazole, even levofloxacin. So this has significantly compromised the success rate of these standard triple therapies. So we must explore the alternative therapies, potentially incorporating newer antibiotics or even combination regimens that can enhance the efficacy while minimizing the resistance. So now let's take a moment to review the current literature on the efficacy of the moxifloxacin in treating the H. pylori infection. When we examine the data across the multiple studies, the moxifloxacin emerged as a highly effective option, particularly in cases where resistance to the other antibiotics has become problematic. So the evidence indicates that moxifloxacin-based regimens are not only more effective, but also associated with a lower resistance rate when compared to the treatment involving the clarithromycin, bismuth-based therapy, and even the nitazoxanide. Now we will move towards the research objective. There are 5 research objectives of our research, in which in the first objective, we compare the eradication rate between the moxi and the levofloxacin-based sequential therapy. In the second objective, we compare and evaluate the safety profile. And in the third objective, we evaluate the patient compliance. And after that, we evaluate the demographic factors and the clinical factors, which may affect the success of the H. pylori eradication. Right. So if you talk about the methodology, this study basically, it was an open label single center prospective randomized clinical trials, and the study conducted at the gastroenterology department of the Jamal Hospital in Karachi, Pakistan. And we recruited consecutive adult patients diagnosed with H. pylori infection, and their diagnosis was confirmed either through endoscopy or the detection of the bacteria in the stool antigen test using the rapid strip HPSA kit. So most of the patients were from the rural region, and it highlights the diverse population that we serve. So this aspect is crucial as it underscores the generalizability of our finding to similar demographic settings. So to ensure the integrity and safety of our study, we established the strict exclusion criteria, which is the individuals below 18 years of age and the patient with clinically significant associated condition and individuals with no allergy to any drug, they all were excluded, right? So at the pre-study visit, we conducted an extensive health history and physical examination. Eligible patients were randomly assigned to either the moxifloxacin group, MAO group, or the LAO-LTO treatment group using a lottery-based approach. Identical paper slips were mixed in the basket, and patients selected slip marked with either M for the MAO group or the L for the LAO-LTO group. Basically, LAO-LTO group consists of the 77 patients, and in this, the regimen was followed. In the first 5 days, the patient has taken the levofloxacin, amoxicillin, and the omeprazole. And the next 5 days, the patient has taken the levofloxacin, tinidazole, and the omeprazole. But in the MAO group, 85, which consists on the 85 patients, in the entire 10 days, the patient has taken the moxifloxacin, amoxicillin, and the omeprazole. So regarding the yes. So regarding the statistical analysis, ITTN per protocol, both analyses were used to evaluate the eradication rates. And the chi-square and the Fisher exact test utilized to investigate the association between the demographic and the clinical variables. and H. pylori eradication rate were assessed. The binary logistic regression model was employed to calculate the two odds ratios, and adjusted odds ratios was determined to assess the magnitude of the association between the H. pylori eradication and the potential factors. And the significance threshold was set as a p-value below or equal to 0.05. So now we are moving towards the results. This is the patient enrollment. Patient enrollment, the study progression and investigation of the H. pylori eradication. The study involved the enrollment of 162 participants infected with the H. pylori, and these participants were randomly assigned to receive either the LAO-LTO therapy or the MAO therapy. And among the recruited patients, a total of 134 patients successfully completed their allocated treatment regimen. And meanwhile, the 28 patients were excluded from the study. From the MOXIE group, 10 patients were excluded, 3 did not receive the treatment, and 7 were lost to follow-up. Notably, no patient discontinued treatment due to the adverse event. In contrast, from the levofloxacin group, 18 patients were excluded, 5 discontinued treatment due to the adverse event, 8 were non-compliance, 3 were lost to follow-up, and 2 did not receive the treatment. The final per-protocol analysis included the 59 patients in the levofloxacin group and 75 patients in the moxifloxacin group. So now I would like to share the finding related to the eradication rate, adverse event, and the patient compliance in both the ITT and the per-protocol analysis. So the overall ITT eradication rate was 70.3%. The study results indicate that moxifloxacin group accomplished a final ITT eradication rate of 81.2%, while the levofloxacin group attained a final eradication rate of 58.4%. So the overall PP eradication rate was 85%. The final PP eradication rate were 92% in the MOXIE group and 76% in the levo group. And in both the ITT and the per-protocol analysis, the Fisher exact test indicated a statistically significant difference in eradication rate between the MOXIE and the levofloxacin group. So these findings is consistent with the results documented in the academic literature. As you can see in the discussion portion that Ahmed et al. Conducted a comparative study between the triple therapy regimen utilizing the moxifloxacin and the clarithromycin, and they suggest that eradication rate were relatively high in the MOXIE group, right? Similarly, in the Akpinar and the colleagues, they also reported that moxifloxacin was superior to the bismuth-based quadruple therapy. So in the next, the total adverse event rate for the MOXIE regimen was 14%, which was significantly lower than the levofloxacin group, which had a rate of 40%. And the findings of this investigation indicate that the incidence of adverse events are significantly elevated in the levo group. Right, and discussion also shows that. Now, if you talk about the severity of the adverse events, so mild to moderate adverse events were reported in the patients treated with a MOXIE, with no adverse event significant enough to warrant cessation of the medication or impede the daily functioning. So on the other hand, in the levofloxacin group, 66.4% of the patient discontinued treatment due to the diarrhea. So the finding of this investigation indicate that along with the intensity of the adverse event are also significantly elevated in the levofloxacin group compared to the moxifloxacin group. Right. So in this, the patient compliance, there were one steady dosing schedule. Patient compliance is also higher in the moxifloxacin group, which is 88.2%, and then in the levofloxacin group, which is 66.2%. And the patient compliance could be high is due to in the moxifloxacin group, there is only the once daily dose schedule, which simplifies the treatment and reduces the dosing errors. And the fewer side effects with the moxifloxacin group, which minimize the adverse reactions and enhance the patient compliance. And it is also a cost-effective regimen as compared to the levofloxacin. So now we will discuss the impact of the demographic variables on the H. pylori eradication. So this study underscores statistically significant difference. If you can see that in the univariate analysis of the demographic factors, we can see that it reveals several significant findings, and there was significantly higher eradication rate in the middle age group with a p-value of 0.0001. And another study conducted by the Yokota et al. Revealed a noteworthy correlation between the middle age group and the successful eradication therapy. And the female had a higher eradication rate compared to the males, and patients with a higher BMI also showed a higher eradication rate. Right, so there is no significant effects were observed regarding the income level, marital status, and the family history in relation to the H. pylori eradication. And as far as the logistic regression analysis examine the impact of the demographic factors on eradication therapy, it includes the variables that showed a significant association in the univariate analysis. In the bivariate logistic regression analysis, 3 variables, age, BMI, and smoking, emerge as significant factors. And patients within the middle age group had 3.6 times higher chances of the eradication compared to both the younger and the older age groups. And individuals with the BMI more than 25 demonstrated 2 times higher chances of the eradication than those with the BMI less than 25. Non-smokers had 2.7 times higher chances of the eradication compared to the current smokers. And in the multivariate analysis, readjustments were made for all the variables on the age, and smoking remained significant predictors for the eradication. Now, the impact of the clinical variables on the H. pylori eradication. So, upon initial enrollment, the symptoms most commonly reported by the patient was abdominal discomfort, accounting for 63.5%, and this was followed by the dyspepsia reported by 55.5% of the patient, and the gastroesophageal reflux reported by 48.1% of the patient. Following the endoscopic evaluation, the gastritis was found to be the most commonly observed condition with a prevalence of 70%, significantly surpassing the occurrence of other identified findings. In terms of the treatment regimen, 52% of the patients received a multiploxin-based triple therapy, while 47% underwent a levofloxacin-based sequential therapy. The outcomes of the univariate analysis investigate the influence of the clinical factors, and the results demonstrate a notably higher eradication rate in patients with the comorbid conditions other than the diabetes or the hypertension among patients experienced dyspepsia and the abdominal pain, and in those treated with the moxifloxacin compared to the levofloxacin. So no significant effect was observed concerning lashing characteristic and gastroesophageal reflux, premature fullness, weight loss, and loss of appetite in relation to the H. pylori eradication. In the bivariate logistic regression analysis for the 4 variables, comorbidities, dyspepsia, and abdominal pain, and the treatment group emerged as significant factors influencing the eradication therapy. Patients with the comorbidities other than the diabetes and the hypertension had the 4.4 times higher chances of the eradication compared to those with diabetes or hypertension. And individuals with dyspepsia exhibit 5.6 times higher chances of the eradication. And patients with the abdominal pain had 1.99 times higher chances of the eradication. And those treated with the moxi had 5 times higher chances of the eradication compared to to those treated with the levofloxacin. In the multivariate analysis, all comorbidities, dyspepsia, and treatment groups remain significant predictors for the eradication. Now, in brief, the finding of the study indicate that the use of the moxifloxacin triple therapy is a highly efficacious and well-tolerated approach for the initial eradication of the H. pylori infection when compared to the use of levofloxacin-based sequential therapy, and moxifloxacin triple therapy may be a viable recommendation for the clinical practices in the Pakistan, given its significant rate of the eradication, excellent compliance, and safety. And moreover, the H. pylori eradication is significantly influenced by the demographic and the clinical factors like the age, smoking, chosen regimen, comorbidities, and the dyspepsia. So identifying these factors enables customized regimens, enhancing eradication success and reducing the associated complications for better overall health outcomes. So these are some future recommendations. And the implication of the clinical practices that implementing the moxi-based therapy could enhance the patient adherence due to a simplified daily dose schedule, and given the higher eradication rate observed with the moxifloxacin therapy, clinicians should consider it as a preferred first-line treatment for the H. pylori infection, and routine monitoring and management of the side effects should be emphasized, and trailing treatment protocol based on the patient demographic can further optimize the eradication success rate. So, in conclusion, I would like to emphasize the importance of the collaborative effort in advancing research on gastric infection and optimizing treatment strategies. And I'm keen to collaborate with the researchers and healthcare professionals at the international level to explore innovative solutions to these challenges. And please feel free to reach out to me at samara.khadem@iqra.edu.pk or samarakhadem01@gmail.com for the potential collaboration or for further discussion. And together we can make a meaningful impact in this critical area of healthcare. Thank you so much.
Thank you very much, Doctor, for your presentation. And now we are welcome to any question from the audience.